Good morning, everyone. Today we are going to discuss the rest of the topics of endocrinology, and I will start right away. So, this is the you can say hypothalamus, pituitary, and the body axis, like all the hormones which are released by hypothalamus. Okay, and these are the list of all the hormones which are released by pituitary. Whereas this one is like endocrine gland or cells, like all the things which are the glands which are present in the body, for example thyroid gland, adrenal cortex, liver, and gonads, of course. And these are the hormones which they release, whereas these are the target organs. Very easy to understand, like there is no nothing complicated in this one, you can say. As you can see, like see this is like growth hormone releasing hormone, and this is gonadotrophic releasing hormone. This is releasing hormone, whereas this is thyroid releasing hormone. So simply all this releasing hormones, whenever these hormones are released, so in response to that, uh, the pituitary release the rest of the hormones like growth hormone or adrenocorticotropic hormone or thyroid stimulating hormone or FSH and LH. Except there is just one, you can say, thing. Prolactin, on the other hand, is under inhibition. Okay, and this inhibition is done by, you can say, dopamine. Okay, so there is inhibitory control by dopamine, and whenever what you can say this inhibition is lost, then it releases the prolactin. Um and this one, like as you can say, that somatostatin is the one which is having inhibitory effect on the prolactin, thyroid stimulating hormone, as well as the growth hormone. So, uh, as we had already covered this one, we had already covered this one, we had already covered like a lot. Of course, like this androgens and estrogen and progesterone and all this one, like they are covered mostly in the gynecology. uh, when you study gynecology, of course, like they will teach you these things over there. And also prolactin. Okay, so as you know, like there is anterior pituitary and there is posterior pituitary, and posterior pituitary releases hormone. One is called as ADH, and one is called as oxytocin. So, like ADH, we have already discussed, like that is antidiuretic hormone. I already had the lecture about diabetes insipidus, right? So, one is oxytocin, which is again you are going to cover in gynecology, not here. So, what is important to understand is the functions of these hormones, and like adrenocorticotropic hormone is the hormone which basically act on the adrenal gland. Okay, and in response to that, the adrenal gland started releasing hormones. Adrenal glands are located above the kidney, and there is adrenal medulla and adrenal cortex, and this is the one which which make different type of hormones like mineralocorticoids, glucocorticoids, epinephrine, norepinephrine. Okay. For example, pheochromocytoma we have already covered, which is a condition which is due to excess production of epinephrine as well as norepinephrine. So, this is the physiology of this hormone. This is a polypeptide, and pulsatile releases there, and there is very variation, like in the morning, in the afternoon, in the night. Okay, so it is highest in the morning and lowest at the midnight, and whenever dexamethasone or cortisol in the body is increased, so it causes inhibition of the release of ACTH. Okay, and these are what you can say the secretory stimulus. Okay, fever, pain, stress, vasopressin, hypoglycemia, metirapone, and so like these all things. By the way, we use in the diagnosis of, like, either if there is raised ACTH or less ACTH. On the other hand, you can see the growth hormones. Of course, like it is very important for the growth. Okay, and what happens? It's also a polypeptide, and acts indirectly through serum and factors, synthesized in the liver, you can say. and there is sustained rise during sleep. Okay, so inhibitory stimulus, you can see over here, there is glucose challenge, glucocorticoids, hypothyroidism, somatostatin, dopamine agonist, and like all this one. So now the important thing to understand over here is like why I'm showing you this thing, because whenever we have to diagnose the conditions, what you can say, if anyone have elevated growth hormone, if anyone have less growth hormone, so what is done, we do the stimulatory or inhibitory what you can say actions, by giving these things. For example, if you want to check like either someone have like when the growth hormone is too much high in adults, we had a condition called as acromegaly. Like what is acromegaly in this one? There is what you can say, uh, like there is macroglossia, bossing of the forehead, the hands become big. Okay, so what we do, by the way, like whenever we have to see like either there is more growth hormone release or not, so we can give this glucose challenge test. Okay, so what we do, we give them glucose, okay, and we see like either the growth hormone levels are what you can say going down or not. Okay, so for example, if the what you can say, if the growth hormone levels are going down, it means like uh, the problem is somewhere else. But like in acromegaly, when we give glucose challenge test, the growth hormone levels, we don't measure growth for hormone levels because like they don't tell what you can say the exact amount of hormones in the body. So like but rather we check this IGF, which is called as insulin growth factor. Okay, one. So basically, what is this insulin growth factor one? Uh, this is a mediator of, you can say, of growth hormone. Okay, so like the growth hormone basically stimulates this IGF. Okay, or insulin growth factor 1. So these are the inhibitory stimulus for growth hormone, and these are the secretory stimulus for the growth hormone. For example, whenever we do exercise, whenever we go into random eye movement sleep, whenever like growth hormone releasing hormone is released, whenever there is hypocalcemia, so growth hormone is released in the body. uh, Other hormones which are there, and as I told you, you are going to study many of them in gynecology. So like LH and FSH is like luteinizing hormone as well as follicle stimulating hormone, and they are more what you can say related with what you can say gynecology. For example, LH, it increases the production of androgens, okay, and which are then converted to estrogens, and whereas FSH, it is the hormone which causes the production of spermatozoa, okay, in testes. Okay, of course, this one, like these are the functions in ovary, and these are the functions in testes. So these are the inhibitory as well as secretory stimulus for them. One hormone is prolactin. Again, prolactin is related with the milk production. Okay, and again, dopamine is the one which inhibit the release of prolactin, as I told you. So whenever like the dopamine inhibitory effect is not there, so the females, they release what you can say prolactin. So secretory stimulus is sleep, stress, hypoglycemia, pregnancy, breastfeeding, and like you would know in gynecology or obs like how breastfeeding is the one which led the release of prolactin. So TSH, we had discussed this thing. What is thyroid stimulating hormone, and how it what you can say regulate the release of thyroid gland. ADH, we had discussed this thing in the previous lectures, and oxytocin, again, it causes uterine contraction as well as breast milk secretion. So oxytocin have many medical uses as well. As you can see, it causes uterine contraction. So like one of the way, when how oxytocin is released when the babies, they suck the nipple of the mother. So in response to that, oxytocin is released, and which causes more and more breast milk secretion. And on the other hand, when the woman, they go into labor and oxytocin is there, it causes what you can say uterine contraction. And that's why sometimes when the labor is not going well, so we give them oxytocin by injection, just to initiate the labor. So these are just the introduction of the hormones which are there in the body, and the different organs which they act on, okay, or the target tissue. Of course, there are many other things which there's a lot of functions, which different hormones are doing. As I told you about growth hormone, deficiency, you can I will tell you, wait. Okay, so growth hormone deficiency, if the growth hormone deficiency deficiency of the growth hormone is there, so what will happen in the children? Like it is going to cause short stature. Okay, like their height will be short if the growth hormone is less in the body. Okay, and in the adults, if there is growth hormone deficiency, basically it is not clinically apparent. Okay, in children. Okay, now. So in adults, if there is growth hormone deficiency, it is not clinically apparent. So that's why you can say it is not going to cause much problem. But in the adults, if there is growth hormone excess, what is going to happen is how the growth hormone excess can be there. It could be anything. It could be a tumor in the pituitary, a carcinoma, or a tumor other than any site other than pituitary, which is releasing either growth hormone or growth hormone releasing hormone. Okay, there are different conditions which can do this thing. Simply, whenever the growth hormone excess is there in adults, it can lead to a condition called as acromegaly. And there are many different clinical features. In children, of course, if there is growth hormone excess, it can lead to gigantism. If there is growth hormone excess in children, so what happened? They get a condition called as gigantism. Okay, so basically they become like giants. Okay, really big. So what happens is growth hormone is a catabolic hormone. It increases the blood glucose level, and whenever there is more and more growth hormone in the body, the secretion is in pulsatile manner. What happened is there is proliferation of the bone, the cartilages, the soft tissue, the organs, and everything become bigger and bigger. So that's the reason. So that's why in children, their bone cartilages and all these things, they become bigger, and they become like giants. In the adults, what is the difference? Why in adults it gives acromegaly, not gigantism? Because in children, when we say children, so remember before their epiphysis are fused. Okay, so if this condition, this growth hormone excess occurs before their epiphyses are fused, so they can lead to gigantism. But if, for example, the epiphysis is already fused, okay, so in children or in adults, so it will lead to acromegaly. So in acromegaly, what happens is there is enlargement of the hands, enlargement of the feet, Their forehead is protruding, their mandible becomes so big, and their skin become thick. Their glands, they become hypertrophic, they produce more sweat, they can develop acne. Okay. uh, and things like this. Okay, so even like the thyroid gland become big. So there are many other complications of this acromegaly, like they may have hypertension. Many of them did, not many, but like most of them, they develop what you can say diabetes. Okay. They develop diabetes, and they have erectile dysfunction. And if it's a female, they have menstrual irregularities and things like this. And one very important thing, the adults, when they get acromegaly, there are different risks, which they develop after developing acromegaly. By the way, in this world, there are many renowned personalities who have acromegaly. So there's increased risk of coronary artery diseases. Okay. Increased chances of myocardial infarction, increased chances of all these things. Their heart become big, called as cardiomegaly, and as well as they can develop myopathies. Okay. So they develop all those things, and many of the patients, they develop this thing. So uh, like most of these people, there is increased risk, like they are going to die because of the heart conditions. So they can develop hypertension as well, they can develop diabetes mellitus as well. So all these things, it can lead to increased mortality, and that's why it's important to treat these patients. Okay. So as I was telling you that whenever, what you can say, we have to diagnose like either anyone have acromegaly or not, what we measure is, insulin type, like growth factor IGF-1. Okay. So whenever like this one is elevated in the blood, because like growth hormone is the one which led the release of this thing. So whenever the IGF-1 level in the body is high, so like this is, you can say, the first diagnostic test which we can do. And then of course, like the slide which I show you, what are the things which can suppress the different hormones, what are the things which can let different hormones to release. So we apply the same formula over here. For example, if you can see over here, what's written for the growth hormone, if you'll see, what are the inhibitory stimulus? Glucose challenge. Okay. When we give glucose, this one should go down. So what we give them, like one of the tests which we can do is like we give them, it is called as glucose suppression test, by the way. Glucose suppression test. Okay, we can do. So what we give them is 75 gram of glucose, of course orally. So we give them 75 gram of glucose per oral. So what it should be doing, it should, if the person is normal, so the growth hormone level should go down. Okay. But if the person is normal, so if the patients, they have acromegaly, so when you will give them the 75 gram of alcohol, sorry, not alcohol, like glucose, what happens is their glucose, their what you can say, growth hormone levels don't go down, they stay high, elevated, of course, like, which means they have this condition called as acromegaly. So of course, like once the diagnosis is done that the growth hormone is elevated, now we have to search the site from where the growth hormone is coming. So we can do what? We can do a CT scan, we can do MRI scan, uh, just to check like where the tumor is located. You can do X-rays as well. These are the investigations we can do to find out the place of this adenoma, carcinoma, whatever it is. So this one is like something important. Now see this one. Inhibitory stimulus is there are dopamine D2 receptor agonist can decrease, right? Somatostatin can decrease the release of growth hormone, and these are the same things which we use, by the way, to treat it. So how this growth hormone is like this problem can be treated? First of all, if you found the tumor site, surgery. Okay, so that's the best way to deal with that. But surgery is not recommended in every patient. But so one of the somatostatin analog, okay, somatostatin analog is called as octreotide. Okay, so one of the somatostatin analog is octreotide. We can give this one. Other one, as I told you, dopamine agonist can be given. So there are different drugs like which are grouped as dopamine agonist, but you can remember a name of a very nice drug, bromocriptine. Okay, but like most of the time, in clinical practice, there is one more drugs, cabergoline. This one is used most of the time. Then it is preferred over bromocriptine. So one of the drug, which is also there, it is called as growth hormone, growth hormone receptor antagonist. Okay, growth hormone receptors antagonist. Okay, because we have to stop the function effect of that thing. So the drug name is pegoisomant. Okay, this is one of the drug which we can give to these patients. So like this is a treatment for the clinical features. Remember like this one. Big hands, big feet, uh, frontal bossing, and macrogenthia, thickened skin, sweaty hands, carpal tunnel syndrome, and acanthosis nigrans, cardiomegaly, diabetes mellitus, hypertension. All these are the features of growth hormone excess in the body. So, like this one is like about growth hormone. Prolactin, as I told you, you are going to cover in gynecology. But like just to tell you, prolactin. What is the function of prolactin? As you know, we had covered this thing over here. The function of prolactin is like it promotes milk production. So what happens, like if someone have, for example, increased level of prolactin in their body, which is called as hyperprolactinemia, and of course, like what can cause hyperprolactinemia, increased level of prolactin in the body, is like if there is a tumor which is producing prolactin. So that's why that tumor is called as prolactinoma. So it's a most common type of pituitary adenoma, by the way, this prolactinoma. So this prolactinoma, whenever like anyone have this thing, prolactinoma or prolactinemia, there are other causes of prolactinemia as well, but what they have, like it is like mostly females, and they have breast milk secretion all the time from their from their breast. Okay, so we call that condition as galactoria. Okay, like urea means like of course some fluid is coming out, so galactoria is the term which is we use for them. So they have amenorrhea, they have infertility, they have galactoria. So anyhow, how we can treat that? We again give them the same drugs, bromocriptine or cabergoline. Okay, because like they are dopamine agonist, and if you can see over here, dopamine have inhibitory effect on prolactin. So what we must give them? Dopamine agonist, which increase dopamine, which will decrease the release of prolactin. So we give them same. And of course, like if it's a tumor, you found the tumor, treat like surgery is a treatment for them. So that's about what you can say, prolactinoma or hyperprolactinemia. If you remember, guys, in pediatrics I teach you hypogonadotrophic hypogonadism, hypergonadotrophic hypogonadism, and all these things. So if when you will study that LH and FSH, you will remember like there is a lot of correlation, and in the patients when there is hypergonadotrophic hypogonadism, what it means that hypergonadotrophic, like the hormones LH and FSH will be higher, but hypogonadism, like the ovaries and the testes, they are not working. For example, someone have hypogonadotrophic hypogonadism. What it means, like the LH and FSH will not be there, as well as the ovaries and kidneys, they are not producing anything because they are not getting any type of stimulus from up. Okay, so this growth hormone, they are released from the pituitary, like you can say prolactin, I gave you example, they are also released from pituitary. So one of the topic which is very important, and which is more like a surgical topic, you can say, is called as pituitary adenoma. Pituitary adenoma. So what is this? Basically, this is a tumor, and what happens is whenever there is pituitary adenoma, it can lead to the production of hormones. Okay, depends if the adenoma is hyperfunctioning. For the adenoma can be hypofunctioning as well. So if the adenoma is hyperfunctioning, so of course it can lead to the release of all the prolactin hormones. And I think by now you must know what are the prolactin hormones, pituitary hormones. Okay, so if there is what you can say, most of the time this pituitary adenoma, whenever it is hyperfunctioning, so most commonly, it produces prolactin. Okay, so that's why we found prolactinemia. Okay, whenever there is pituitary adenoma. But okay, it can produce growth hormone, it can produce ACTH. What will happen if it is producing prolactin? We already discussed, like I already told you, there will be hyperprolactinemia. Okay, which will lead to what? Which is going to lead to what you can say, galactoria. I'm just writing what you can say one feature, but as I told you, there will be infertility if it's a male, there will be menstrual problem if it's a female. What will happen if growth hormone is released in increased quantity from pituitary adenoma, acromegaly, we are talking about hyperfunctioning pituitary adenoma in adults, or gigantism in children? What will happen if it is going to release more ACTH, for example? So what will happen? It is called as Cushing disease, if you remember, like my previous lecture. Okay, so depending on what kind of hormone it is producing, it can produce LH, FSH, TSH, any hormone it can produce. So when the pituitary as a whole is hyperfunctioning, or it is releasing multiple hormones, which is never a case, it is called as pan hyperpituitarism. But it is a case that sometimes the adenoma is hypofunctioning and it depresses, or like all the pituitary hormones are lost. We call it as pan hypopituitarism. Okay, so one thing, because this tumor is in the pituitary, and pituitary is located very close to optic chiasma, where the optic nerves, they are crossing over. Okay, the fibers, they are going on the other side. So whenever the people, they have pituitary adenoma, many of these people, they have visual field defects. And what happens, like they have vision loss on the sides, or bitemporal hemianopia. Okay, what happens to these people, like when there is any pituitary tumor? We are discussing, of course, pituitary adenoma. It's a tumor, so it can lead to what? It can lead to pressure effects on the optic chiasma. Okay, it will pressurize optic chiasma, and what will happen, like basically the fibers which are coming from the nasal side, they are going to cross over on the other side, so they will be compressed. So there will be bitemporal hemianopia. Okay, like as you know, like the nasal side fibers are going to make you see the things from the temporal side. Okay, if you're not sure about this thing, just open what you can say, how the visual work, and you would understand what I'm saying. And these are the people, because they have this thing and their nerves is compressed, so they may develop diplopia, and they see double images, as well as you can say they can have headache as well, okay, due to pressure effects. So like this is how this one present. So one of the thing I told you, hypopituitarism is there, which of course, like, which can lead to um, like decrease, which can cause hypopituitarism or panhypopituitarism. All the hormones will be decreased. There will be no TSH. The patients will go into hypothyroidism. There will be no growth hormone. There will be no ACTH. There will be no prolactin. So many things. What are the causes of hypopituitarism? Can be remembered by 8 eyes. Okay, so this is 8 eyes. 1, 2, 3, 4, 5, 6, 7, 8. So one of the thing is, invasive. What is invasive? Like, pituitary tumor is something which is invading the pituitary gland. A carcinoma is something which is invading the pituitary gland. Infarction, for example, there is infarction in the pituitary gland, or hemorrhage simply. In that case, it is called as Sheehan syndrome. In this one, that what happened is, like, there is pituitary infarction postpartum when the females, they give birth, a topic which again you will study in gynecology. There can be some infiltrative conditions like sarcoidosis or hemochromatosis. Okay, so they're like infiltrative or inflammatory conditions can be there. There can be some infections like syphilis, okay, TB. Then there can be injury, head trauma. Then there can be immunological conditions which can lead to hypopituitarism, like autoimmune conditions. Okay. Then there can be iatrogenic, like, for example, the surgeon performs some surgery for adenoma and they remove a big part of the pituitary. So no pituitary, no hormones. And there can be idiopathic, okay. Familial causes can be there, congenital causes can be there. So like these are all the causes like which can lead to we should add one more thing here. These are the causes of hypopituitarism. Okay, so below are the causes for that. Okay, so this thing, of course, like, if there is hypopituitarism, what is the treatment? Guys, simply when the treatment is done, how the patient will present. There is no ACTH, there is no glucocorticoids, there is no mineralocorticoids. The patient will present with fatigue, with weight loss, with hypoglycemia, with anemia. There is no growth hormone. If it's a child, they will be having short stature, but if it's an adult, of course, it's not clinically much evident. When there is no TSH, the patients will go into hypothyroidism, no LSH and FSH, amenorrhea, decreased libido in males, or many other issues like muscle mass will be decreased, no prolactin, of course, no breastfeeding in females, no ADH, diabetes insipidus, and of course, like, if there is no oxytocin, so that will be evident when there will be breastfeeding. There will be no production of milk. So simply, how to treat them? Provide them with the missing hormones. Provide them with all these hormones. Okay, and like, of course, nowadays all the hormones are available, and we can provide the patient with all the hormones, like thyroxine, like glucocorticoids, like all these things. All these things, hormones can be provided to the patient. Okay, so that's about this thing. Quickly, I will go. Like, this is the last lecture for endocrinology, and that's why I'm winding up all the topics. And as I told you, most of the time, They just teach diabetes and thyroid disorders. They don't touch any other topic, but I'm just at least touching the topics. Okay, so that's why I'm covering these topics as well. So, talking about the adrenocorticotropic hormones, I remember like ACTH is released and it acts on the um adrenal gland, and the adrenal gland have what you can say adrenal cortex and adrenal medulla. Adrenal medulla produces norepinephrine and epinephrine. Check the lecture of your chromocytoma. Adrenocortex have three layers. Remember GFR, which is glomerular filtration rate, but here G is zona glomerulosa, F is zona fasciculata, and the R is zona reticularis. So glomerulus produces mineralocorticoids, aldosterone. Now, if you know the function of aldosterone, it is the hormone which basically regulates the ECF, extracellular volume, through controlling sodium channels, okay, and potassium channels, okay. So whenever this aldosterone is released, it basically stimulates the sodium potassium ATPase pumps in the distal tubules, okay. I will repeat again. Whenever aldosterone is released, what happens? It regulates the ECF by regulating sodium and potassium, okay, excretion. Basically, what it does, it stimulates distal tubule sodium potassium ATPase, okay. And this aldosterone is regulated by renin angiotensin aldosterone system, or you can say RAAS system, which you had done many times in physiology, okay. So if you forget that part, go read RAAS system. Very important. Many drugs are there which act on that. Very important. Zona fasciculata produces glucocorticoids, cortisol, okay. Now, if you know what is cortisol, it's a glucocorticoid. It regulates the metabolism, okay. It counteracts the effect of insulin. It supports blood pressure. It supports the vasomotor tone, and it regulates the behavior as well as immunity. So whenever there is the release of cortisol, what happens? That it stimulates gluconeogenesis. It increases insulin resistance. It increases protein catabolism, as well as like it decreases fibroblasts. It suppresses inflammation. It inhibits growth hormone, okay, and many other things, okay. You can go through the functions of aldosterone. Whereas in zona reticularis, it produces androgens, okay. And the androgens which are important, is DHEA, which is dihydroepiandrosterone, dihydroepiandrosterone, as well as androstenedione, okay. And of course, like, what is the function of androgens? As you know, uh, androgens are the one which like the testosterone and all the sex hormones and the body mass and all this one. Of course, they are controlled by this thing. Now, like, as you can see this photograph, okay guys, see this one. Basically all these things, this is dihydrotestosterone, for example, or what is this? This is aldosterone, this one. What is this? This is cortisol or estradiol. So whatever it is, either it's mineralocorticoid, either it's glucocorticoid, either it's sex steroid, all these things are formed by one precursor that is called as cholesterol. So like, this is all the flow chart. Of course, I'm not going to discuss this thing, but you can see like cholesterol is the one which is forming. Like, these are the number of like the enzymes. You can see, you can read like what enzymes are there. Okay, number one, this enzyme is there, and if you remember, we had in pediatrics, we had done one thing called as uh, that congenital adrenal hyperplasia. So what happened, like in that one, this hydroxylase enzyme is missing, and that's the reason uh, like what happens, like they cannot make this hormones. So simply one precursor cholesterol is there, and it is the one which give all the hormones, which give rise to all the hormones. Okay, so there are different type of for example, 5 alpha reductase is the one which is changing testosterone to dihydrotestosterone. And like many of the drugs, they are used, which are basically 5 alpha reductase inhibitors. When you will study benign prostatic hyperplasia, you would know what is the function of this thing as well. So again, I like, this is the renin angiotensin aldosterone axis. Actually, I expect from the students, like they must be good in this thing before going to study anything clinical. I see this one, like decreased volume in the blood, decreased arterial pressure. There is decreased sodium to the macula densa in the kidneys, and what happens? That there is what you can say, the activation of this juxtaglomerular apparatus, which and renin is released in the kidney. It goes, which convert angiotensinogen to angiotensin 1, and in the lung and kidney there is angiotensin converting enzyme is there, which convert angiotensin 1 to angiotensin 2. Okay, and this angiotensin 2 basically go and let the release of what aldosterone from zona glomerulosa, which causes renal sodium retention and potassium excretion. Why? Because it activates sodium potassium pump. Now, why I'm showing you this thing? Because you can correlate a lot of drugs, in pharmacology, which act on this system, like ACE inhibitors. Okay, so what is ACE inhibitors? We give them in multiple conditions, even in hypertension and things like this. So whenever like the blood pressure is increased or the volume is increased, the arterial pressure is increased. So what happens, like of course, like the kidney have what you can say retain much sodium, so there is inhibition of juxtaglomerular apparatus. So this thing, guys, and glucocorticoids, I already told you the functions. Okay, remember the one of the function, one of the glucocorticoid, which is very important, and which is called as cortisol. Okay, so now cortisol, you must know the physiological effect of these hormones. Okay, what it do and what will happen, that when they are absent. So like cortisol is the one which regulates the metabolism by stimulating the production of glucose in the liver, a process called as gluconeogenesis. Okay, it increases protein catabolism, like all the things which I told you before. Okay, other than that, now what happens is the same thing which I show you in this photograph, this one. Remember this thing, the ACTH is inhibited by dexamethasone and cortisol, right? And the secretory stimulus is by giving all this one. Okay, corticotrophin releasing hormone and like all these things. Okay, so we supply the same things, in the diagnostic workup. Okay, diagnostic workup for adrenal gland. Okay, so what is the what kind of diagnostic workup is there? For example, if someone adrenal gland is not functioning, so we have to what you can say diagnose. We have to check for hormone deficiencies, right? So how we can detect hormone deficiency? Of course, we need some sort of stimulation test. Okay, what is stimulation test? What a stimulation test is simply we must give something which should increase the release of hormones from the adrenal gland. So what is the hormone? which can increase the release of hormones from the adrenal gland. Remember, guys, ACTH. Okay, so when the ACTH is released, the adrenal glands, they release the hormones. So if we want to check either the adrenal gland is functioning fine or not, we can give a thing called as co-synthropin. What is this, by the way? This one is same like ACTH, okay? Or you can say it's a ACTH analog, like something same like ACTH. So that's why it is called as co-synthropin stimulation test. What it means, like when we must give this drug to the patient, okay, we give it IV. So what happens is in like when we give this drug in IV to the patient, it must do what? It must cause the release of cortisol. Okay, so this is one of the what you can say tests which we can do to check like either adrenal gland is working or not. Okay, but then there is some sort of, okay, so this is a stimulation test, right? This one is a type of stimulation test in which we are stimulating the gland. Okay, now there are different suppression tests as well. So what are suppression tests? Of course, like we must give something which should you can say suppress the production of the hormones. Okay, for example, I will tell you again, refer to the same see this thing. Okay, these are the one which suppress the release of pituitary, like this adrenal gland hormones. So now, of course, what is the function? Why we use suppression test? This one is to detect the deficiencies of hormones. Okay, and these tests are done. Suppression tests are done when, for example, someone is producing too much hormones like aldosterone, cortisol. If the cortisol is produced too much, what will happen? Cushing syndrome. Okay, if aldosterone will be present too much, what will happen? Hypertension. Okay, if androgens are too much in the body, what will happen? Too much hairs on the body. Okay, and especially in females, hirsutism. Okay, and many other, like their body will start becoming like males and things like this. So suppression tests are used to detect what you can say the hyper secretion of hormones. Okay, if the body is producing too much hormones or not. Okay, so like I hope like you understand. The thing is very simple. If the hormones are not there, so we must give something so that the adrenal glands should produce more hormones, and by that way we know like either the body is like the adrenal glands are functioning or not. Okay, and if, for example, the body or the adrenal gland are producing too much hormones, we must give something which should suppress that hormone, so that we should know like it's the adrenal gland which is hyper functioning. So one thing is called as dexamethasone suppression test. Okay, so same thing. See, guys, dexamethasone suppress this one. So when we give dexamethasone, it must suppress ACTH. Okay, so what we do, by the way, as we know, like when we give dexamethasone, the ACTH level should go down. So what we do, we give the patient dexamethasone and we wait overnight. Okay, we can give oral medication of dexamethasone tablets, and we measure the cortisol level in the morning. Okay, and one of the tests we can do is we can do what you can say 24-hour urine free cortisol as well. Of course, like if the level is high, it means like that adrenal glands are producing too much what you can say cortisol, okay, or glucocorticoids. So dexamethasone suppression test can be used, and we can use some other test. For example, one test, it is called as extra cellular fluid volume expansion, extracellular fluid volume expansion with normal saline. Okay, so what we do, by the way, simply when we give someone too much normal saline, okay, normal saline, what should be, what should happen? Too much fluid in the body, aldosterone should suppress. Okay, so what we give, we give them IV infusion of normal saline. Okay, uh, for like 500 ml we can give them in 4 hours, and after that we measure the level of aldosterone. Okay, if the aldosterone is still high, what it means that, of course, uh, adrenal gland is producing too much aldosterone. Okay, so see, this one is to check the cortisol or glucocorticoids. This one is to check the aldosterone, or you can say mineralocorticoids. Okay, now see guys, one of the thing, very easy thing, by the way, very easy concept. uh, Whenever the mineralocorticoids are excess in the body, so uh, mineralocorticoid means aldosterone, what will happen, it is going to retain more and more and more sodium in the body, and the patient will be having what? Hypertension. Okay, so whenever anyone have hypertension, now see, very easy concept guys. If you found any patient who have hypertension due to aldosterone excess, what aldosterone do? It activates the sodium potassium ATPase pump. What it means, it retains sodium, it throw out potassium. So if hypertension is due to excess of mineral or corticoids, okay, which means aldosterone, then there should be hypernatremia with hypocalcemia. Okay, so whenever we found that someone have hypernatremia and hypocalcemia, it means there is excess of what? Excess of aldosterone. Okay, so what we do, by the way, we do more two tests. We check plasma renin activity. Again, the important thing, guys, go and study renin angiotensin aldosterone system. Okay, then you would know like why we are checking this plasma renin activity, as well as we also check plasma aldosterone concentration. Okay, because we know now that there is excess of aldosterone, but we must know, like, either it is renin which is too much, either it's adrenal glands which are producing too much. Like, where is the problem in that whole system? So simply, if for example there can be three outcomes of this thing. See, one outcome is simply, okay, this one is also called as a PRA, and this one is also called as PAC, PAC and PRA. So one of the condition can be what? PRA is increased, okay, as well as PAC is increased as well, or simply renin is increased as well as aldosterone is increased. The other possibility can be what? That PRA is decreased, okay, and PAC is decreased as well, which means like both aldosterone as well as renin is decreased. And the third possibility can be that the PRA is decreased, whereas PAC or the aldosterone is increased. Okay, and now so simple. See, if renin is increased and aldosterone is increased, and I will take you there as well. Aldosterone is released, renin is released from the kidneys. Okay, so now in this case, renin is increased, aldosterone is increased. So what it means, guys? It means that if the problem is in adrenal gland, we call it as primary aldosteronism. Primary aldosteronism. Do you think in this one, when the renin is increased, it is primary aldosteronism? No, it will be what? Secondary aldosteronism, which means that there is increased renin, which is causing the production of increased aldosterone. So what it means, that we must find out the tumor, for example, which is producing more and more renin, or it is the kidneys which is producing more and more renin, or maybe the patient is using some diuretics. That's the reason it is there. Second condition, in which the PRA is decreased as well as aldosterone level is decreased. So one of a very, very, very common cause is congenital adrenal hyperplasia, okay, of this thing. As well as there are many other conditions. For example, someone who is taking um, mineralocorticoids by tablets, okay, and one of the cause can be Cushing syndrome. Then there are some congenital disorders like Liddle syndrome and things like this. But if the renin is decreased but aldosterone is increased, so simply it is what? It is primary hyperaldosteronism, okay, or primary, you can say, aldosteronism, okay. So it is called as primary aldosteronism. Okay, I hope you guys understand this thing. Okay, so primary aldosteronism is like, there is excess aldosterone production. Secondary means like there is both renin as well as aldosterone production. Okay, one thing, guys, when someone have primary aldosteronism, which means like the adrenal glands are the one which is producing more and more and more, what you can say, aldosterone. So one of the cause of this thing is what? Adenoma, okay, or simply you can say adrenal adenoma, which adenoma is producing more and more aldosterone. We call this condition as Conn's syndrome. Okay, and then there can be adrenal hyperplasia. There can be other things as well. So most of these patients, they present with hypertension. Remember, hypocalcemia, and we investigate them by how I told you how we investigate them, what we have to do, and we can quickly reach the thing. So simply, anyone who have this mineralocorticoid excess syndrome, we have to inhibit the you can say either aldosterone or the action of aldosterone. Okay, aldosterone. Okay, we have to inhibit the action of aldosterone. Guys, if you will correlate this thing with the pharmacology, you would know the best drugs. Spironolactone. Spironolactone is the drug which we use to do this thing. Okay, spironolactone, eplerenone, amiloride. Okay, amiloride is a drug which basically acts on the sodium channels. Okay, of course, like surgery to remove the adenoma is one of the treatment as well. Okay, so the Cushing syndrome, which is due to excess of cortisol or glucocorticoids, we have already gone through. Okay, and the third thing which we were discussing is androgens. And guys, whenever there is androgen excess, there is more androgens in the body. What happens, in females, they have hirsutism, they have male type of pattern of growth of the hairs. Okay, their muscle mass is increased. Okay, and one thing we call it as virilization, in which like they become muscular like males. Okay, they have increased musculature, their voice change, their clitoris can get enlarged, they got acne, they got temporal balding like males. Okay, or simply the female sexual characters will start disappearing, they will look like more like males. Okay, and in males, of course, because males have already these features, so any type of hyper androgens is going to give minimal effect on males mass, or what you can say, hairs. But when they have decreased level of these hormones, their testis size will decrease, and there will be less spermatogenesis in the patients. Okay, so that's all about what you can say about the endocrinology lectures. Okay, one of the thing which I believe you guys have already covered, guys, one very important thing, uh, go through the parathyroid hormone regulation, how it works. Parathyroid gland is the one, like whenever there is decreased level of calcium, parathyroid hormone release, parathyroid gland release parathyroid hormone, which go and act on kidney as well as osteoclast activity, like it release more and more calcium from the bones. Okay, so simply in the kidney, what it do is like it increase the calcium reabsorption, or simply parathyroid hormone increase the level of calcium in the blood. It add up the calcium from the bone by osteoclast activity, as well as from the kidney by reabsorption of more and more and more calcium. Okay, this one looks so complicated, but it is not that much complicated. You can see, like, we can take the vitamin D by in diet, and like we need UV light to activate them, cholecalciferol, and that is converted into, like, in liver it is in the form of 25 hydroxy vitamin D. In the kidneys, it is going to change into 25 hydroxy vitamin D, and so on and so forth. Okay, so like the net effect, simply whenever the parathyroid hormone is released, it increase the level of calcium in the blood. Okay, and decrease the level of yeah, phosphorus in the body. So just go through this thing. Why? Because there are two things. One is called as hypercalcemia, which have a lot of causes, and one thing is called as hypocalcemia, which have a lot of causes. Okay, these things are important. Okay, clinically, there is a mnemonic, you can say. The last thing, of course, like after that I'm going to finish this topic. What are the clinical features? Okay, clinical features of hypercalcemia. Hypercalcemia. So what are the clinical features? Remember, there is a mnemonic called as, there are many mnemonics, bones, stones, groans, and psychic or psychiatric. So you can use anything. So I will use psychic, psychic moans. Okay, so you can remember it like by bones, stones, groans, and psychic moans, or bones, stones, groans, and psychiatric tones. Okay, overtones. So we can remember it by this way. So hypercalcemia can be there in many of the conditions, like carcinomas. Okay, increased level of vitamin D, sarcoidosis. Okay, there are many conditions which can give. Familial causes are there as well. So whenever, like, the patient, they have hypercalcemia, they develop hypertension. Okay, and they develop constipation. Okay, they have constipation, anorexia, nausea, vomiting. Okay, so see, groans, constipation, and abdominal pain, of course. Okay, so whenever they have nausea, vomiting, they have constipation, they have abdominal pain, so they make like groans. Okay, and now they have polyuria, they have polydipsia, but the important thing is they develop renal stones, or nephrolithiasis. Nephrolithiasis means what? Stones. Okay, so abdominal pain and constipation means groans. Okay, so they develop a lot of renal stones, so that's why they have this thing. They do have gout, pseudo gout. So hypercalcemia, of course, like, it is coming from the bones, so they have weak bones. Okay, or they have like too much pains in the bone, and they experience pains. Okay, so see, remember bones from this one. And these people, they go into anxiety, they go into depression, and there are many organic brain syndromes which can occur when the calcium levels are too high. So that's why, remember, psychosis. Okay, they have PSY, psychosis. Okay, so remember from moans. Okay, so bones, stones, groans, and moans. Okay, they do have other features, like they may have arrhythmias, they may have hypotonia, hyporeflexia, all this stuff, but you can remember by this way. So treatment is, of course, like treatment of the underlying condition. Okay, so that's for all for today lecture, and I will see you in the next lecture.